Good evening, everyone. Namaskar, Sat Shri Akal, Vanakkam. A very welcome to yet another webinar in the series of 7 webinars, which are being hosted by infection control nurses. And I'm very proud to say they are my students. And this is my one way of ensuring that I support young nurses into this is what I commit as CEO of Signia Healthcare. So, ladies and gentlemen, all of you know my name is Sankam Kumis. I am the founder CEO of Signia Healthcare. And today I'm very happy to invite all of you to join this webinar. This webinars are being, organized by Healthcare in association with, Nurse India. And Nurse India is the technology platform which is exclusively designed only for nurses. So I really hope that you will visit the website and join there, because it is supposed to be a one-stop solution where you get all information about nursing. So these webinars are being organized in celebration of Infection Prevention Week that happens in October. So we have 7 webinars that we have planned. And I'm sure that all seen this post. The first webinar was hosted by Halle on non-ventilator pneumonia, well attended. I should be hosting that video today on our YouTube channel. Today, 14th October, we have got Rakshita talking about extravasation. So we have selected topics in which we could be having new information, where we need to attend web, read more articles so that we get to know what is the latest. Hopefully, through these webinars, we'll be new information as well. We keep it all free because we are committed to patient safety. So next in line on 17th October, we have Rajesh. She will be speaking on strategies to prevent in acute care settings, followed by Ashwati speaking on SSI. Then we have Amandeep talking about cleaning and disinfection, environmental hygiene. Then we have Blessy speaking about CLAPSY, and then Feba about PAP. Isn't it all interesting, Larissa? Very happy that so many are interested and they are joining in the I'm sure that all of you care about patient safety. And when we talk about patient safety, preventing patients from getting any infections while they are hospitalized is one of the basic requirement. And it is our responsibility not to harm the patient by giving them anything more than what they have come to us to heal. And we are there to provide an environment without harm, including not catching any infections. So hopefully these webinars should sensitize us to how we can prevent complications in our patients. So without much delay, it gives me immense pleasure to invite Rakshita here. Rakshita, are you here? Can you put on the video, please?
Yes.
Yeah. So a very, very welcome, Rakshita. And there are many people already joined. So we have already 50 people, quite popular, seems like. So that's great. And, so I have not told anything about you. I'm only going to tell them your infection Manipal Hospital, Yeshwanthpur, Bangalore. I request you to speak little bit about yourself, and then introduce yourself, and then your presentations.
Thank you so much, ma'am. It's my privilege. I'm so excited as well. My name is Rakshita. Basically, have done my graduation in the Mysore Medical College, Government College. And next, I done my post-graduation in BMS College of Nursing, Bangalore. Totally, I'm having 6 years of experience in that, 2 years as a infection control nurse. in the Manipal Hospital, Bangalore. So before start the session, I would like to show my gratitude to my guru and my teacher, Tangamma. Thank you, ma'am, for this wonderful platform. This is all we follow your steps, ma'am. This is a good opportunity to. These all sessions will create us to learn more, research more, read articles. We can gain knowledge, ma'am. Through that, we can gain confidence also. So we can teach many in the CNEs, uh, like this webinars. Thank you. Thanks a lot, ma'am.
You're most welcome, and I'm very happy to be, giving this platform to all young leaders. You are the future, so I want to invest in the future. So, it's all yours. So, ladies and gentlemen, please make sure that you stay off the video and off the audio. And if you have questions, please continue putting it in the chat box. And after Rakshita finishes her discussion, then we can address some questions and we can take some comments. So, thank you very much. Rakshita, over to you. Now I'm going to stay off the audio and video, and I'll just manage the backend.
Sure, ma'am. Once again, a warm evening to all. I'm so glad and thank you everyone. So you all be in the time actually. So we'll get into the very interesting topic. Is the day-to-day topic is all about extravasation.
Can you put
So
light show?
yes, sure, ma'am. I was okay, no, ma'am. So extravasation. Can anyone say what term will confuse with extravasation? Definitely is a infiltration. So in further slide, we will say how to classify between the extravasation and phlebitis with the infiltration. Okay. So this session's all about the extravasation. The objectives of this session is knowing about what is extravasation, what are the types of and what are the causes and how we can manage and how we can prevent the extravasation. Okay, basically 80% of the patients who are admitted to the hospital, they are undergoing that IV access. So if the patients are in IV access, definitely they are risk of IV complications. So let us have a quick review of what are the IV complications. So phlebitis, extravasation, infiltration, hypersensitive reaction, thrombus, occlusion, dislodgement, and air embolism, isn't it? So, what is extravasation? Extravasation is all about it is inadvertent administration of the vesicant medications, or we can say in a simpler word, is a leakage of the vesicant drugs into the surrounding tissue. Okay, so see this is one example for the extravasation is a grade 1 because of the chemo or cytotoxic medication, and second picture you can see because of the high or osmolarity medication administration. Okay, so we can see the both adult and the neonate are the equal chance of getting extravasation. Now we can say what is infiltration. Very simple. Infiltration is a leakage of non-vesicant drugs into the surrounding tissue. Extravasation is a vesicant drugs leakage. Okay, so if you see the incidence, 0.1% to 6% are risk at the patients or in a peripheral line. If you can see here, 0.2 to 4.7 because of this through the central lines. So here we can make the difference between the more risk in the peripheral axis. Okay. If you see causes mainly because of the antineoplastic, ionotropics, osmotically active agents, certain antibiotic. If you say we are very familiar with the antineoplastic, because all about the chemo drugs, isn't it? And inotrophs are usually we call it as a vasopressors. Osmotically active agents, example for osmotically is a sulfurs and we can say amino acids and certain antibiotics, usually higher antibiotic. Example, vancomycin. These are all the commonly used medication which may lead to extravasation. So be cautious about when we are administering these drugs. If you see very broadly, generally we say cytotoxic vesicants and non-cytotoxic vesicants. This is a general classification. We can do that. Okay. If you see cytotoxics is all about the chemo drugs. Example, doxorubicin, vincristine, vinblastine, daunorubicin, epirubicin, etc. If you see non-cytotoxic, it's all about the calcium chloride, hypertonic solutions. Example, calcium chloride, magnesium sulfide, and vancomycins, antibiotics, dextrose. If you see like this, any administration of this medication, if you found any extravasation incidents, you can put it in a chat box, and end of the session we can discuss how you face this challenge and how you manage. Okay. Next, based upon the classification of intravenous drugs, we are categorized under the 5 categories. One is vesicant, exfoliants, irritants, inflammants, and neutrals. Now we see one by one. Why we want to know this? Because if you know this, it's easy for us to do a management. Management is easy for us. If you know the characteristics of agent which cause extravasation, then we can easily know how we can manage. Okay. So now we see before that pathophysiology. Take it as vesicant. Okay, for example, you take vincristine administration. What happened if you administered inadvertently, that harming the epithelial lining of the blood vessels? That leads to the triggering and releasing of the oxygen free radicals that trigger the inflammation. That inflammation causes the sign and symptoms of extravasation. Okay, if you see here clearly, you can see here the second picture, tip of the catheter, isn't it? So here, administration of any vesicant drugs happen here dislodgement, isn't it? Because of this dislodgement, these drugs are leakage into the outside of the blood vessels. Okay, that is exact what extravasation will cause. Can anyone say what second picture will saying about? Second picture shows that generally what we have to do, we are in the 0.9% of normal saline or sterile water, we are flushing the line, isn't it? Before administering of the medication and after the administration of the medication, we are flushing the line. Why? Because to maintain the patency of the line, isn't it? If you are not flushing the line, directly I'm going to give the this vesicant drugs, what will happen? It will stop. Then it will backflow of the drugs will happen. Then that leakage around the tissue. Okay, that in turn cause the extravasation. This is a simple understanding of pathophysiology. Next, we'll see what is vesicant. See, if it's so sad to see this because it is late recognition and the timely treatment not happen, then that leads to this necrosis or death of the tissue. Okay, so if you see what is vesicants, vesicants are the drugs that potentially causes the blister and ulceration. Okay, then which is lead to the tissue necrosis when is left to untreated. Okay, then in this vesicant we have a two types. One is DNA binding drugs and non-DNA binding drugs. We see example for the DNA binding drugs are daunorubicin, doxorubicin, epirubicin, okay, mitomycin C, like that. This is all the DNA binding classification. If you see non-DNA binding drugs, only three types. Three drugs are there: vinblastine, vincristine, and vinedicine. Okay, now I'll show you some pictures. You can see here, this is first image happened because of the administration of the epirubicin. Okay. Second thing you can see, this is administration because of the vincristine. Okay, so we should very careful when we are administering the vesicant drugs. Okay. Second one is exfoliants. What is exfoliants? Exfoliants are the drugs which cause the inflammation and peeling of the skin without causing underlying tissue death. Exfoliants will never cause necrosis. Okay, this is a difference between the vesicant and exfoliants. Okay, so you can see example for cisplatin, doxorubicin, mitoxantron. You can see here image. This is because of the mitoxantron adjuvant administration. Okay, this is because of doxorubicin. This is the classification of exfoliants. Next, we can see irritants. Irritants are the drugs that cause the inflammation, pain, or irritants, but without causing the blister formation. In this irritants, blister will not form. Okay, for example, you can see bendamustine, bleomycin. Okay, these are the example for the irritants. See the image you can see. Here, the blister will not form. Okay, but you can see the erythema there. Okay, next is the inflammants. Inflammants are the drugs that cause mild to moderate inflammation. Okay, painless skin erythema. Only erythema we can say here. Okay, example for bortezomib and fluorouracil and methotrexate. Next, we can see neutrals. Neutrals is neither cause inflammation nor damage. But if if you're giving the forceful administration, then that turn into the extravasation. Okay, these are the examples as per Genius. You can see these are the example for the neutrals. Next, we'll see what are the risk factors for the chemotherapy extravasation. First is the patient factor. As we first slide itself, I told that both infants and the adult are equal risk of the developing this extravasation. Okay, but we will say infants and the young children. Why? Because they have a very fragile vein and very small, isn't it? So infants and the young children and elderly patients, vulnerable patients, and the patients who are receiving the chemotherapy drugs, the patients who are under the anticoagulants, the patients who are under the steroids, and the patient who are having a fragile veins. Okay, and the patient unable to communicate, so they can't say no. For example, if one of the live example I can say, one patient is unable to speak. Okay, what happened, they are under the radiology contrast. She can't explain the burning sensation is happening while going the contrast. Because of that, later staff came to know that, oh, there is a extravasation. Okay, this was the one of the example. So those people are the under the risk of this developing the extravasation. If you see second factor related to chemotherapeutic agent, means sometimes we all know the characteristics of one drug is different from the another drug. Okay, so as a nursing staff, we should know what volume we have to give, what dosage we need to give. That all matters. Okay, so we have to give a time to, for example, if any chemotherapy drug is started, means we should know what is the drug characteristics and what mg we need to give. Okay, this is all very important. Otherwise, what happens, this in turn cause as a risk factors. Okay, and iatrogenic causes, as I said, is a lack of training of the nurses, new joinees. Okay, they don't know, like, are they give this highly concentrated drugs or osmotically agent drugs through the IV. So suppose not, we have to give through the, always prefer the central lines line or the chemopods, or we can go for the jugular vein, isn't it? So otherwise, what happened? Definitely, it will cause the extravasation. And poor cannula size selection. This is a very important thing. We should know what size of the cannula should take to the what size, the size of the blood vessel or the vein. In further slide, I will explain how to take. In the management slide, I will tell you how to select the vein and what gauge we need to take. Okay, so these are all the poor location selection and lack of time. These are the cause for the risk factor for the extravasation. If you see the clinical manifestation, as we all know, for the sinus, first sign for the phlebitis, what? Phlebitis first sign is pain. Okay. But in the extravasation, first sign is a burning sensation. Okay. Start from the burning sensation. Then it will lead to the stinging pain, then swelling and erythema and induration and the skin discoloration. Okay. Sometimes what happen, we unable to put the plunger when you are administering the drug. That also one of the clinical manifestations. Sometimes what happen, if you leave untreated, it will cause the blister formation, finally lead to the necrosis or the death of the tissues. Okay, these are all the clinical manifestations. Now we see how to grade the severity of extravasation. There is a total 5 grades. Grade 1 is a none. Okay, no sign and symptoms. If you say grade 2, we start by the erythema with the associated symptoms like a burning sensation, edema, or the pain, induration, and the phlebitis. Okay, and grade 3 is ulceration or necrosis, means severe tissue damage. Is required operative interventions. If you see grade 4, is a life-threatening consequences, urgent interventions indicated. Grade 5 is a death. Okay, so these are the 5 grades of, if you want to see the severity, we can grade according to like this. So now you see how to manage the extravasation. This is very, very important. See, step 1, stop the infusion immediately. This is the first step All the nurses we have to do. Okay. Second important thing is do not remove the cannula. You leave the cannula where it is. Okay. The first foremost, stop the infusion, then do not remove the cannula. Second step, disconnect the infusion. Okay. Third is why we had to leave the cannula, because we can aspirate as much as drug surround the tissue maximum. Okay. This is the reason why we have to leave the cannula in the place. Okay. Then we can use a 10 ml of syringe to remove the maximum vesicant drugs around the tissue. Step 4, collect the extravasation kit. Okay. Can anyone in your institution having extravasation kit? Is yes. Then you can put it in a chat box. What are the items which extravasation kit should have? If no, definitely I will explain in the next slide. Step 5, mark the area, affected area by the marker pen, or you can take picture, photo of that. Why? Because we can see after our intervention whether the prognosis happen or not. Is easy for us to grading the prognosis. Okay. So step 6, then you remove the cannula. Then check which category of drug is belongs to. Either is a vesicant, either is a cytotoxic, or non-cytotoxic, like that. Then that help us to decide what kind of management or what kind of measure we have to take. Okay. If possible, if required, we can administer the paracetamol or the paracetamol infusions or anything required pain relief we can administer. Step 9 is a decide an appropriate damage limit management. Last step is documentation. Okay. Next, we'll see how to prevent the extravasation. We all know prevention is better than the cure, isn't it? So after having extravasation, treatment is difficult, but before only we'll do is a very vital action we need to take to prevent the phlebitis, to prevent the extravasation is very, very important, is all in a nurse's hands. Okay. So we should be very master in this. So if you see the prevention, as we all know, the thorough education is very much important. We are undergoing the continuous nursing education, CNE, isn't it? So always we should give a priority for the phlebitis and the extravasation. Okay. Then all the staff, especially for the new joinees, are well aware of that, how to prevent such complications. Okay. The second thing, we have to educate the nursing staffs, like what are the characteristics of the drug, especially for the vesicant drugs and the cytotoxic drugs. Second thing is we have to select appropriate vascular access. What my request is, give a time when you're assessing the line vascular access, no, give a more time to access properly. And one more mantra is, should not use the dorsum of the hand or the cubital. Okay. Always, and don't take the radial and ulnar as well. Just choose the cephalic or basalic vein is a very best choice. In this access, definitely we can prevent extravasation. Okay. And one more thing is, always any vesicant drug or any cytotoxic drug, if you're administered, kindly go with the central line access or jugular vein you can try. Okay, till the chemopod, till the central line insertion, you can easily access the jugular vein. Okay, this is a special indication. Then we have to be ask the patient any previous venipuncture happened. Okay, how many times, and we can check the level of conscious of the patient is all important. Second thing, appropriate equipment. As I told, see, this is important. Smallest size of cannula into the largest vein available. Okay, this is a very, very important thing. Otherwise, what happened? Dislodgement of the vein one happen and double puncture is happen. So if you select, ideally we can say 20 gauge cannula is a well sufficient for all the administration of antibiotics as well as the vesicant drugs, anything. Okay, 20 gauge cannula is more than enough. Yes. Can anyone mute your this one?
Yeah, muted.
So second thing, educating the patient is important. For example, if you not educate the patient will tolerate themselves. One incident happened again in the radiology only. they think like that, okay, maybe this kind of what is that, contrast, like this the nature, so I need to be tolerate. The patient is tolerating that burning sensation. Then later we came to know there is a happening of the extravasation. So educating the patient is very much important. We have to educate them whether through the what is that, infusion time, if you feel any pain or any burning sensation, anything, kindly inform us. Okay, this education of the patient is also important. And very much important is flushing the line before and after the administration of the any medications. One question: if you're not, for example, entire day only BD is there, vancomycin, not BD, OD we can consider, OD only. No? So OD, if you are giving any medication, what we can do till next day, the line is as such. So what we can say to our nurses, each shift, either you are giving medication, not the medications, you can flush the line. Each shift, flushing of the line with a 0.9% of normal saline is more than enough. That really helps us a lot to maintain the long time patency. Okay. So second thing, kindly avoid the vesicant infusion not more than 60 minutes. Only 30 to 60 minutes for the vesicant administration. Okay. Should not more than 60 minutes. See, you can see this is the extravasation kit. This extravasation kit have a these are all the items we can see. Hyaluronidase 150 to 1500 units. This is an intradermal. Then hydrocortisone topical application and the hot applications, cold application pack, everything we should keep. 10 ml syringe also to aspirate as much as okay. Now we see we have anyone have a confusion like either we have to use hot application or cold application. Anyone can say which we have to use. Either we have to use hot application or cold application.
Cold. Cold
Cold.
application.
Why?
Already hand bottom is burning. If you keep hot application, it will be very burning again.
Oh, very good, Ramya. Means the simple or what we say, no, most of the extravasation management we are using the cold application only. Why? What is the a common phenomena in that? Because cold application will cause the vasoconstriction, isn't it? Hot application will cause dilator vessels so that blood flow is more and it will can worsen. But you can see for the Win alkalides and this etoposide, except these three, okay, in rest of all the condition we can use the cold application. Only for this vincristine, vinblastine and etoposides we had to use warm application. Okay, it's very simple. And please keep in your mind the temperature of the hot application should be below the 140 degrees Celsius and should not more than 20 minutes of duration. Okay. So most of the extravasation we can use the cold application. Only this Win alkalides and etoposides we can use hot applications. Okay. Take home messages. We should be very cautious whenever we are administering the vesicant drugs, okay, and always prefer the central lines, okay. Then importantly, if you have extravasation kit in your institution is very well, then immediate action, okay, immediate recognition assessment very important. What I'm telling, if you not a confidence to what is that, to difference between the phlebitis or extravasation, kindly call upon your seniors or who's expert to assess what happened. Okay, you have a infusion nurses and your seniors and doctors, so you can stop the infusion. You can call immediately if you are not capable of assessing. Okay, and if you are or if you are unable to manage, means you can do that. Otherwise you can call up your seniors. Don't take the risk because patient safety is our goal, isn't it? So this is all about. I will wind up my sessions. I request Sangam ma'am, if you want to add any points more, you can, ma'am.
You can stop sharing, Rakshita.
Yes, ma'am.
So thank you very much. That was a little bit of a fast train going through many slides. So I really hope, I would like to ask the audience that, would you like to share any of your comments or, any questions that you may have? Please, the floor is open. So there is a question that has come in. Could you please let us know what are the antibiotics causing?
Usually higher end antibiotics, for example, vancomycin and all the higher antibiotics are the risk of causing the extravasation.
So the intent is not to, the idea is to know the medicine which is already labeled as something extravasasis can damage the tissue. I have not used much of chemo in own experience. I'm a critical care nurse, but I have used inotropes. At least I know that dopamine had in one patient caused, necrosis, because it was done in a peripheral vein, and then it leaked out, and then by the time the damage was already done. And dopamine is a vasopressor. At certain dose, it becomes a, so the dose at which the patient was getting was at vasopressor level. The patient fortunately did not lose his fingers. So I think the takeaway message, what is there in extravasation, the basics. One is, how do you select a vein? This is very, very important. Yes, cortisone can also cause. Cortisone is again one medicine known to cause, damage if it gets extravasated, So adrenaline, noradrenaline. So the most common ones that causes maximum damage are the chemo drugs, which that Rakshita has, mentioned. So the takeaway from here should not be to know that which drugs are going to. Could you please explain duration for restricted antibiotics? What is that? What is that restricted antibiotics duration? See, first of all, there is no duration that is standard given to any nurses. Please understand, it is expected that the doctor should be writing for how much time a drug needs to be given. I will not like to tell that to any nurse, even if I know. Usually these drugs are given over certain period of time. It is, please don't learn like that. It is always better to remember, I'm going to ask the doctor to write the complete order, not half order. Never take that, because I have seen disastrous actions being, taken by nurses because the doctors didn't write the full, order, and the nurse was not aware that I cannot do this. So at least basics, every nurse can learn that I should only carry out orders which are complete, where it should be written the complete name, legibly it should be written, the dose should be written, the route should be written, dilution should be written, and for how long it should be infused, everything should be written. What is the action of hyaluronidase?
Yeah, hyaluronidase is one of the the collagen kind of. Okay, if it is it will reduce the what we say whatever the leakage of the fluid, it is reduce and it will bind the tissue to tissue. That is one of the action for the hyaluronidase.
Okay, we anybody else would like to add answers to the questions, please feel free to do that. What is the recommendation of flushing the line? Who is recommended for strictly fluid restriction? Sorry, is the question that, if there is recommendation for flushing the line for a patient who is on strict fluid restriction? Is that the question, Ramya?
Yes,
If the
ma'am.
on strict fluid restriction,
Yes, because we will see in the renal cases who is very strict in fluid restriction, who is on OD dose antibiotic, and we cannot flush the line each and every time, because each time when we ask to the flush the line, they will take at least 5 ml. 5 into 3 shifts, it will become 15 ml. Then they, if they are staying for 3 days, it will become already 100 ml.
15 into 3 days will not be 100 ml. That
I
is
mean,
what-
at least 50 ml it will come now, ma'am. If they taken orally plus
But-
IV, it
but
will be
if
100
you
ml.
will not flush the line, the lines will get blocked.
Because usually consultant will tell to close the line. They will pack up till they get the dialysis. They will pack the line. They will not allow to open
You're
us.
talking about the dialysis lines or the peripheral lines. What are you talking about?
Lines only, ma'am. Peripheral line or dialysis line, any lines. Because they will be in the, sometimes they will be in without catheter, they are getting dialysis now, ma'am.
Okay, without catheter, they are getting dialysis, peripheral line.
Hmm.
So, how do
So
you block?
some
What is the protocol for blocking, I mean, keeping those lines patent?
Yes, ma'am. That is my question. Because sometimes they will get dialysis in fistula. So there is no HD catheter.
Okay,
So
so
if they have IV cannula, if they admitted in the hospital, usually we'll ask for flushing, na, ma'am.
it is not necessary that every line needs to be flushed every time. The doctors will decide whether the patient needs repeated saline flushes, okay, or you are going to put a heparin lock. So the doctor has to
yes,
decide
hep lock.
that, because let us ask the audience sitting here, what is your experience of patients who are on strict fluid restriction? See, when I was a ICU nurse, patients who are on fluid restriction, those who are on dialysis, 10-15 ml of fluid was not a major problem. Unless you are supposed to be giving something every 4 hourly or something like that. So, because anyway, they are going for dialysis. So that much of fluid is anyway taken care of. Patients who are on dialysis, they are on fluid restriction, but it is not that you cannot give any fluid. And in those cases, based on the patient's, coagulation parameters, you may decide to put heparin flush, so that you are not flushing the line repeatedly. It is a patient to patient decision. This is what I experienced, because earlier days we used to use heparin flush for all patients. Now it is all stopped, and now the flush is only saline for all peripheral lines, correct? So you have to get the nephrologist to order what is it that we can use, because it's a good question to ask the nephrologist, ki, sir, the patient is on this many medication, so we are going to flush the line this frequently, or patient is not getting any medication, you have kept the IV just to have an access. That is also a debatable question, whether you need to keep one IV access just like that. So in renal failure patients, there is a restriction of fluids. Obviously, you cannot have IV saline running to keep the vein open. That is not a good suggestion. So you will have to lock the IV cannula. So let me ask the nurses who are sitting here, what are your practice in the dialysis patient? If my patient is in SVC, how can it lead to extravasation? If it is in the SVC, obviously it will not extravasate. Extravasation usually happens in the peripheral veins because they are not there in the vein correctly, or the vein walls are very fragile. So that question does not even arise. This in the central line. That is why central lines are recommended for vesicants and or any drugs with high osmolarity. So somebody is telling we are using NS flush for peripheral line and HD line for kidney failure patients. Monica, the question is how many ml and how frequently are you giving? That's the question. Can we use glycerin maxil dressing after application of ice pack? I have not heard this as a treatment anywhere. Donkey years ago, I have seen this, and since I had left ICU in 1997, but I did not use them from 1982 onwards. I have not seen glycerin max self dressing, not even available. So, are you people still using glycerin max self? Is it available? I'm not sure. Do you have it? Hello? Hello?
Available, ma'am.
Sorry?
Available, ma'am.
Yes,
It's
ma'am.
available, ma'am.
It's available. Oh, okay. And what do
Yes,
you do?
ma'am.
What do you do with that? What do you do with that? Where do you use it? By that, meanwhile, let me try to answer another question. Any of the investigation required, like any culture or any investigations before starting an antibiotics according to advice? Now, obviously, there is a doctor's order for taking culture. No nurse can take it. But there could be a standing protocol that any patient suspected of sepsis, a culture has to be taken before you start the antibiotic. It all will depend on the treatment and what's the diagnosis of the patient. Like, for example, if someone is already aware that the patient is having pneumonia, you're starting an antibiotic. There, it's not a standing order to take culture. But any patient who is suspected of sepsis, you will have a standing order in the hospital. You have to take the culture, and your antibiotics have to go within 1 hour of the patient reaching the ER. It is very, very important because that's one of the major criteria for sepsis management, that the culture needs to be taken before you give the antibiotic. Superior vena cava disorder, then how can it lead to extravasation? I don't know. I don't understand the question. I'm sorry. What are you trying to ask? Superior vena cava disorder. What is the superior vena cava disorder?
No, ma'am, there is a it is there in the list of causes of extravasation. So I just need to know that how superior vena cava or SVC can lead to extravasation. It is there in the slide also.
Was there in the slide, or she was mentioning that it should be central line and peak line is preferred to
No,
be?
I am not. No, ma'am. I was just asking that it is something SVC is something which is related to superior vena cava disorder.
No, I'm not sure. Rakshita, just go through your slide. You don't have to share, just check what is she trying to ask. I'm not very sure. Max self with glycerin applied dressing. Okay. See, if you look at it, I can tell you that you need to share, just check where it is. Rakshita.
Yes, ma'am.
Without sharing, just check where is that SVC word coming. Don't disturb the audience. Okay.
Okay, ma'am.
No problem. So I'm trying to see the questions. We'll come back to that. But Rajni, okay. Rajni, as far as I know, superior vena cava cannot lead to extravasation unless the doctor manages to puncture it through. The patient will not even survive if you puncture your large vessel. So there is nothing like that. All the central lines and all the PIC lines, whichever you call it as central vascular access devices, they will end up in those large veins. So I don't think that that's an answer. Did you find anything there? Rakshita, did you find anything?
I'm checking.
South.
Yes,
Okay,
ma'am.
says I
1
belong
minute, ma'am.
government sector, it is very difficult to follow even simple procedures. Should there be a SOP for? Obviously, all these things that is being told, they are all covered under procedure manual. There must be SOPs. Without that, you cannot go ahead and do any of those things. Because extravasation, how they are managed will be there. How the drugs should be diluted. There will, all of them will have guidelines or SOPs for making sure that everyone is following the same thing. Okay. Okay. The question. Yes, Rakshita. Was there something?
Ma'am, here they say there's a patient factor, the chronic diseases such as a cancer, peripheral vascular diseases, and superior vena cava syndrome and
Uh,
lymphedema. These patients are at risk like that is there, ma'am.
okay.
So that should.
Just open the slide now. Share the slide. Let me try to explain that.
Okay.
That's a very excellent observation, I should say, that out of all the slides you try to ask that question. It's good. Let's open the slide. Okay, risk factors. So, please keep quiet. Can you put it on slideshow?
Yes.
Okay, Rajini, I think this is the one you're talking about, right? So these are disorders. Okay, if you have major vessel disorders, whether it is peripheral vascular disease or if there is superior vein, generally if there are vessels which are not good, and lymph, these are different diagnosis. So in case if they are having bad vessels and you then you are using those vessels, that is that's the only thing that one need to keep in mind. And obviously these things will be considered by the doctors before they put the central line, whether you can use a vessel. These are cited reasons for which you cannot even put a central line. Forget about the extravasation, but by mistake if you put it, it can extravasate because of the basic problem the patients have. I hope that is a pretty basic answer that I have given.
Good evening, ma'am.
Good evening.
Can I contribute something, ma'am?
Yes, please.
Immediately, even I have read that. So this superior vena cava syndrome is just the obstruction that you have already told, partial or complete obstruction of the blood vessel that flows through the superior vena cava. It can be the thrombus formation, can be the reason, or tumor infiltration of the vessel wall. These are the main reasons that blood flow will be obstructed. That can be the reason. This is at the patient factor.
So any vessel. Thank you very much. I don't know who was speaking. Thank you very
To
much.
Devinder, ma'am.
Okay. You're always present there. Thank you very much. Any vessel for that matter, whether it is superior vena cava, subclavian, external jugular, we know that external jugular, internal jugular, you cannot use it if patient has got increased intracranial pressure. That has got another reason for that. So obviously, if you use a vessel which is suitable to be used, you will end up having problem. And then that's something very basic. But here, what I would like to suggest to all the nurses, how do you prevent extravasation? I mean, that is the question. Obviously, the doctors will decide that whether I can put a central line or not. The nurses will not be deciding on that. It is a doctor's thing. I would like you to tell me that what did you take away? What are you taking away from here that when you are giving these medications through peripheral IV cannula, if you have to, what will you do? Somebody already wrote here proper vein selection. Thank you, Rekha. There was something more that, Rakshita mentioned there. What is that? Very, very important thing. Can someone mention?
Size of the cannula.
Yes, very good. Size of the cannula. What was the size of the cannula talking about?
20 she has mentioned.
Sorry?
20.
18 gauge.
I was waiting to hear that 18 so we can have a discussion, because we all think larger veins are better. Larger cannula, not veins, larger veins. Please understand that is not the case. That is not the case. And what Rakshita mentioned was that you should use larger vein, but the smallest cannula that you can use. The cannula size, the diameter of the cannula should not be more than 50% of the diameter of the vein. So if you have a vein of this size and you put a tight fitting 18 gauge cannula, I can guarantee you within 24 hours, there will be phlebitis. Because you don't have enough circulation around the cannula is tight fitting. So it is rubbing against the wall, which is making the intima of the vein wall to be inflamed. And anything that inflamed can start to leak if you don't take care. So most of the things that you need can be taken care with a 20 gauge cannula. I mean, there is a lot of information around what is the flow rate and all that stuff. So one part is the dilution part, that what is the recommended dilution for the drug that you are using in hand, and then what should be the size of the cannula. I mean, this is not something the doctors are going to write. This is something that the nurses should be understanding, and then using their common sense. We should not always think that bigger cannula is going to give us reserve the bigger cannula for, very high rate of, fluid patient who comes with trauma, and, you have to give them fluid and blood. In that case, it's okay to use an antecubital fossa and, you give your, fluids 18 gauge because you want to run the fluids very fast or the blood very fast. But for anything else, a regular infusion, she already mentioned, please avoid this and this. And Infusion Nursing Society recommends 4 hours. So Rakshita mentioned cephalic and basilic vein is what you are going to use. And another practical thing that I would like to emphasize upon everyone here is, please spend time finding the right vein. Please don't go after the first vein you see. Please spend a moment to think about, why am I starting this IV cannula? What drugs are supposed to go through this? Based on that, you will decide, this is the cannula, this is the vein I'm going to use. I'm not talking about emergency situation. There it is a different story. I mean, you are not waiting to think a lot, what, when, there the most safest thing is to find the largest vein and put the cannula and start your treatment. And yeah, someone mentioned observation of cannula frequently. Ask the patient any pain while administering vesicant drugs. Yes, absolutely important to continue watching the patient. In our Association of Nurse Executives India, that we have collected 100, case studies, which is now under print. In another 2-3 weeks time, the book will come out. In that there is one case study. It's a very, very interesting. The nurse started the IV. She just put the cannula, flushed, and connected the IV, and she went. It was night duty. When she came back, she realized, I don't know how did she manage to cannulate the artery. I have no idea. The blood was actually going back to the fluid. That's the time she realized, I have never come across anything like that in my life. So what I'm saying is, we forget the basics. You cannot do things just like that, just pick up something and put the IV and, just flush and connect and run away. No, we are supposed to spend time finding the vein. While you are inserting, talk to the patient, ask them whether there is pain or anything, see, why I'm telling this incident is to tell that, all kinds of problems can happen when we are not present with the patient, when we are not talking to the patient, asking the patient whether they have pain. This is very important. And when you are using vesicant drugs, it is even more important. Another common problem that can happen, I will tell you what happens. You have put a cannula and it has been there for 2-3 days. After 2-3 days, the doctor has ordered for a irritant drug. It can be even KCL or, Cordron. So you go there and just disconnect and just do a flush and then connect without actually observing the site. Sometimes what happened, the cannula has been there for 2-3 days and you have not used it. There could be a slight resistance when you are trying to flush. What you try to do is you forcefully flush and now it is patent. So when you forcefully flush, the the infiltration is the fluid leaking out. Extravasation is a vesicant leaking out. It's the same thing. Whether it is fluid or is the vesicant drug, it is leaking out of the vein. And that can happen to many reasons, whether the cannula came out of it or the vein wall has become very thin or it is inflamed or it is leaking out. So all those things can happen. So talking to the patient, observing the patient is the most important thing. Always check there is no leakage from cannula. Yes, as this means cannula is dislodged and more chances of extravasation. And and another thing is when you have a cannula, if at the entry point, if you see that the area is becoming wet, you're giving something, the fluid, but it is going, your fluid is going, but there is some backflow, just the fluid is coming out from the hole. It is a warning sign that definitely it is going to infiltrate. After some time, the swelling will definitely happen. Don't always say, pain, pain, pain. Patient might say no pain also. But there are some patients who don't feel any pain.
Pain.
Time that pumpkin or the tennis ball has formed. Then they will say, oh my God, all the fluid. Huh? But there is another theory, you can give fluid simultaneously. When you don't get veins, we know that, right? Intraosseous and subcutaneous fluid administrations are tried when there is no other access. But anyway, that is not the discussion here at all. We are not allowed to give fluid in the subcutaneous tissue. So basics, ladies and gentlemen, is very important. I am trying to, ask Max, what's that? What is the dressing you said? I'm
Magnesium sulfate, ma'am, MGS for 4. Ma'am, I would like to add few points, ma'am. So my literature says that the topical application of the hydrocortisone 1%, and either we can use the dimethyl sulfoxide application, ma'am. But the effect of the MGS44 dressing is very less in case of extravasation, ma'am. That is not action is no actions on that exactly. But either we can use hydrocortisone or we can use dimethyl sulfoxide applications, ma'am.
Okay, okay. So I'm also trying to ask here that is there, there is no indication. I am asking my chat GPT, magnesium sulfate dressing, what is it used for? It is not talking about infiltration or extravasation. It's talking about many other things. So olden time, Maxell dressing was used on boils and abscesses, right? Olden time, So it is talking about the same thing only. So Maxell is not recommended. So I don't know if you people are still using it. That is not the current recommendation, at least, that we can definitely tell. So what it is telling is these are recommended only for abscesses, boils, infected wounds, sprains, strains, the there is this plaster you get, no? The one with the, what do you call it? Black colored, that you put on boils so that they, ripen fast and it will burst. I don't know, I have used it many years ago. So that contains, magnesium sulfate, the basic
No,
part.
ma'am, that was the belladonna plaster.
No, not belladonna. Is it belladonna? I don't. Was it belladonna?
Yes, ma'am. Yes, ma'am. It will removes the reduce the pain and
Oh,
swelling.
is it available? No.
No, not now. Not now. It's
Okay.
not now available.
Are you as senior as me, Monica?
Yes. Yes.
Really? Okay. But nobody is more senior than me, huh? I'm 65.
No.
Okay. Extravasation kit once more. Rakshita, you can put that slide up once again, please. Share extravasation.
Sure, ma'am. Sure, ma'am.
So those who want, you can take a screenshot. Put it on the slideshow. Sofratul, bactigras. So these are all, with antibiotic. Bactigras and sofratul all have antibiotic uh, inside those dressings. So they are used for wounds. So they are not for extravasations.
This heat pad is written like just now we are discussed that we have to use cold application, and now it is written heat pad instant. So
No,
could you explain that?
cold pad
Ma'am,
is required. Heat is only if the particular heat pad means not instant to give. It is like the pad is instant. That means you can heat it up if required instantly. It's not a gauze that you will boil and make it hot or something. Already Rakshita mentioned where you can use warm compress. Only for that you need to keep a heat pad in the kit. It's not that you are going to use it for all. So the heat pad is something that you will just plug it into the electric socket and it will warm up. So you have that.
Oh.
Cold pad also should be, wrapped and ready in the freezer because you cannot keep it in the kit. That's the only meaning there. Yep. Interesting discussion.
like only 3 drugs, ma'am. Vincristine, yes, ma'am.
This indelible pains, what? Maybe I have not heard. Anybody can tell me.
What's that?
Indelible pain.
Indelible.
Huh.
Indelible. Pen means that's something that come off easily because you have to. Indelible pen is the one that you are using for marking surgical site.
Okay. Okay.
That will come off, when you are cleaning with something, because you have to mark the borders of the extravasation just to see it's not getting worse. So that is one of the step that you have to do. When after you leave the cannula in, you aspirate, and whatever skin changes are there, you will use it to mark it and keep observing that whether it's spreading or not. Am I correct, Rakshita? Yeah?
Yes, ma'am.
Yes, ma'am.
Okay, okay. I have not worked in chemo, but I know the basics because in ICUs, we are worried about all those medicines that we are using. For
Ma'am,
phlebite, be done. Yes, please. Somebody was saying something.
ma'am, limb elevation can make any difference in this situation?
No. Usually that will not help because the drug has gone into the tissues. The limb elevation usually works only when there is a, infiltration of fluid and you have swelling. When you have swelling, and that, it makes it more tight, and even the blood vessels can get squeezed inside those interstitial tissues. So you just reduce the swelling. If there is swelling, you can raise up. But if the drug has extravasated, it is not going to help because it's already leaked out in the tissue. No, raising it up will not help. So I think the moral of the story here is we should not allow that thing to happen at all. That is the most important thing, because in my 16 years of career in critical care, I have seen only one extravasation in a very old patient. The dopamine extravasated, and there was severe lack of blood supply. It actually went bad, but we could save the digits of the patient. I've only seen it once. I don't think I have seen bad extravasations otherwise in my career. So if there is phlebitis, what do you do for phlebitis? This phlebitis is not extravasation. No? Please don't confuse extravasation with phlebitis. Phlebitis means simple inflammation of the vein. Rakshita, you can stop sharing, please. So what are your practice? If a patient develops phlebitis, what do you do? Hello, all practicing nurses are here. Please answer. What do you do when you get a patient with phlebitis? Hello. We have lot
We
of.
have to be.
Obviously, you remove the cannula. Then what do you do?
First, we have to, according to the VIP score, we have to do, ma'am. We have to grade the phlebitis again.
I got it. I'm asking the group sitting here, what do you do if patient gets phlebitis? What action do you take after removing the cannula?
Ma'am, applying the thrombophob ointment.
Okay.
And ice pack, madam.
Ice pack and?
Yes.
Thrombophob
Then first we
ointment,
apply the ice pack.
Okay. Again, nice these actions. Try to catch them before it becomes worse. The moment patient says pain, it is better to remove. Don't tell the patient, it's normal to have pain. It is never normal to have pain. Only at the time of insertion, you may get little pain, but after that, when the fluid is going, you're not supposed to get pain. If you are getting pain, there must be a reason. Maybe your antibiotic, which was supposed to be diluted at 10 ml, you diluted in 2 ml and you are giving. So obviously the patient will get pain. Or the drug that is supposed to be, all the IV drugs are supposed to be given slow. Any drug that you give intravenous, it's a standard protocol. You will give it slow, except for one medicine. Anybody can tell what medicine? We are already 8 o'clock. I thought, we are going to wrap up.
Adrenaline.
Adenosine.
Adenosine.
Yes, very good, very good. I understand that. Okay. Rakshita told, hydrocortisone ointment recommended instead of magnesium sulfate. Okay, thank you. So adenosine, anyway, we'll not get into cardiology questions now. So these are some basics, if you keep that in mind, you can give safe care to the patients. So I think, thank you very much, all of you, for being here. I think it was a very interesting topic. So a lot of people came, they had asked a lot of questions. Thank you for being an interactive audience. And we look forward to having you again on 17th. Yeah. When we talk about, what is the next topic? Do we have any idea, or even I forgot or you forgot?
Critical care management.
This is the strategies to prevent infection in acute care settings. This is actually more of a larger discussion that what are the strategies one should adopt to reduce hospital-acquired infections in hospitals. And definitely it is a good topic for all nurse leaders and infection control nurses. I really hope all of you will come and, listen to that topic. And then we have SSI. So interesting topics coming out. We will be sharing all the details in all the groups, and we look forward to seeing you. And all that you miss, you can catch them on our YouTube, Signia Healthcare's YouTube site. Okay. All right. Thank you very much. And Rakshita, thank you very much for being here. Thanks, Dr. Davinder and Dr. Jyoti, for joining. It kind of
Thank you so much, ma'am.
encourages the young nurses that when they
Thank you,
speak,
madam.
there are seniors also who come in to listen. That's a very motivating thing for all of them. Thank you very much.
Thank you, ma'am.
Oh,
My nurses are also attending, few of them.
Thank you, ma'am.
thank you. Take care, Rakshita. Bye-bye.
Bye. Good night, ma'am.
Bye. Bye-bye.
Thank you, ma'am.